Today I don't see anyone in the waiting room. What's going? Is it a different connection?
They are in the waiting room. I haven't given you.
Oh, you not made me host.
Yes,
not made me
not yet.
Co-host. Yeah, that's why I can't see people in the waiting room.
Prior to the dawn of democracy, there were very few opportunities for people living in townships to access quality, private healthcare at affordable rates.
It was difficult then to get into private practice because most private hospitals only admitted white patients.
You know, those days are apartheid days. Patients were allowed in the private hospital, but I was not allowed to go and see the patients there. At one stage, I was the only black specialist in this country in private practice. I was a pioneer going to white hospitals. I could see the reverse. That black doctor is here again.
Skilled black medical staff were employed at government and private hospitals far away from where they lived. And the community who required private healthcare services had to travel long distances to hospitals located in formerly white areas, often at considerable expense. In the late 1960s, a group of visionary businessmen, including Dr. G.M. Piche and Mr. Richard Maponya, under the leadership of Dr. N. Motlana, formed a company whose purpose was to establish a medical scheme and private clinic to serve the disadvantaged communities. In 1985, the group opened its first private hospital, Lesedi Clinic, now renamed Dr. S.K. Matseke Memorial Hospital, finally realizing their vision of bringing private quality healthcare to township areas. That led to the formation of the Clinics Health Group in 1992. It was the futuristic ambition of Dr. Peter Matseke that saw the current and continuing growth of Clinics Health Group to greater heights. Clinics also facilitated the advancement of previously disadvantaged doctors by enabling them to open their own specialist practices in these underserviced communities. 30 years later, Clinics continues the legacy by being a respected healthcare group consisting of 6 private, state-of-the-art hospitals located in Soweto, Johannesburg, Vosloorus, Vereeniging, and Mafikeng. Together, these hospitals have over 1,500 beds and 23 operating theatres. Facilities include ICU beds, 24-hour emergency units, renal dialysis, mental wellness services, and 24-hour urgent care. Clinics continues to attract top healthcare professionals, which enables us to meet our mandate of providing a high standard of healthcare products and services, quality patient care, and friendly service. Clinics is committed to providing economic opportunities by ensuring that procurement is outsourced to local businesses, supporting entrepreneurs and ensuring a bright future for all. We continue to be administered by a team of diverse and highly skilled medical practitioners who, being rooted in the community, know just what you need to thrive. Clinics Health Group. You are family.
Good evening, colleagues, and welcome once more to our weekly webinar hosted by Clinics Health Group. I see the tagline says Clinics Health Group, your family. We're in the process of changing our tagline, and to watch this space. In a few more weeks' time, we'll be launching a new tagline, moving away from we are family to something more exciting, all embracing and depicting what our vision is within clinics and what we hope to achieve in the next coming years of the existence of this business entity in a health group, Clinics Health Group. It's also a pleasure for me once more to welcome you to our weekly webinars. We've been doing this for the last few years, since 2020, when we went on a lockdown and started these virtual meetings, and we found that you like these webinars, and we're quite excited and quite appreciative of your support over this last 2.5 years or so, in that we are able also to bring these webinars because we've got willing participants, clinicians, researchers, and colleagues who are both in the public and the private sectors from across the various disciplines and health professions, who are prepared to come and share their knowledge with us on a weekly basis. And hence we're able to maintain this relationship and the service that we are giving to the community within the health sector, as we want to become known as a thought leader in medical education and continuous CPD services that we provide, and also to promote quality healthcare knowledge within the healthcare industry. And so this evening, we're quite excited that we partner with the MSD. We're able to bring you one of the specialists within the sectors, both public and private sectors, who are with us, and we're quite grateful to MSD for partnering with us. And before I introduce Vuyo Fadana, Dr. Vuyo Fadana, who's the medical advisor for infectious diseases within the MSD entity, just please note that these webinars are CPD accredited, and also that when you register, please do provide us with your full details, your name, surname, and email address, and also your contact numbers. And don't forget to give us your registration numbers, whether you are with the HPCSA, with the Nursing Council, of the Allied Health Professions Council, the Pharmacy Council, or just a friend of the healthcare practitioners. You're quite welcome. And the meetings presentations are also available on YouTube, because these are flighted live on YouTube, so you can have access to the recordings after the presentations, immediately after the meeting. We also sent survey questionnaires, so that you give us feedback as to how you find these presentations. And lastly, please do not put your names on the chat groups because we've got your details, and it is not necessary to put your name and surname and your practice number, because that information should have been provided for when you registered, and that information will be uploaded and given to the various entities that will give you the certificates. So without any waste of time, I just want to introduce Vuyo Fadana. Will be introducing our guest speaker this evening. As I indicate that from time to time we do partner with MSD. And if there are any colleagues who are working with other pharmaceutical companies or other entities who are prepared to partner with us, please do contact us, and you can send an email to webinars@clinics.co.za or raybila@clinics.co.za. Thanks, Vuyo.
Thank you, Dr. Bila. So it is my pleasure to introduce today's speaker, Dr. Mamokoma Becky Kgole, who's a pulmonologist at Dr. George Mukhari Academic Hospital in Ga-Rankuwa. Her roles include managing the high dependency unit, which has 11 beds, consisting of 10 ventilator beds and 1 high care, as well as a medical unit at the institution. She is also a head of one of the medical units and is in charge of overseeing the running of that unit. Dr. Kgole is affiliated with the following societies: the South African Thoracic Society, South African Critical Care Society, American Society of Chest Physicians, European Respiratory Society. She's very passionate about mentoring young clinicians and has so far supervised 5 MMeds. So without further delay, we'll hand over to Dr. Kgole to give us today's talk. Over to you, Dr. Kgole.
Yeah, Dr. Kgole, I don't know if it's me or it's everybody else better to hear you. I don't know if Voyo and Kamu, can you hear?
I think Doc is struggling with network. Her bandwidth is low.
Yeah, so apologies. We'll try and sort out Dr. Kgole's network.
So apologies for that. Dr. Kgole just got disconnected, but we'll be joining in a few seconds.
Okay, thanks, Voyo. Yeah, please to get you'll be in touch with us. So colleagues, we apologize for this. Dr. Kgole's bandwidth was a bit of a problem, but everything was working well. I don't know what happened just before as we started with the presentation, but as soon as she's reconnected, we'll continue with the presentation. So please bear with us for a few minutes. So colleagues, we trying to reconnect Dr. Kgole. We'll see if she's rejoining us. She was disconnected, so we trying to make contact with her. Should be reconnecting very soon. For those who've just joined us, just to know that we having a because when you registered, you saw that there's also we getting Dr. Becky Kgole, who's a pulmonologist, will be giving a talk this evening on update on the management of nosocomial pneumonia. We're following up on the discussion that we had last week in pediatrics with Professor Velapi when we were discussing challenges that we find in the neonatal units due to infections. But tonight we mainly with the adult sector, and Dr. Mamokoma Becky Kgole is a pulmonologist at Dr. George Mukhari Academic Hospital in Faragua. And also her role includes managing the medical high dependence unit at Dr. George Mukhari, which is about 10 ventilator beds and 1 high care, as well as medical unit at the institution. She's also the head of one of the medical units in charge of overseeing the running of the units. She's affiliated with a number of societies, Thoracic Society, the Critical Care Society, chest physicians and American chest physicians, and the European Respiratory Society registration. And she's passionate about mentoring young doctors. So Dr. Kgole is about to rejoin us now. So give us a few minutes, she's rejoining us. And when I was talking to her earlier on, I was saying that seeing that she's talking to, mentoring young doctors, we also want to encourage young specialists who are in clinical medicine or training, and also to be now that as we celebrate Youth Month, we also want to hear more from the younger doctors. So if any one of you is interested in doing presentations in June, we're quite excited. You're quite welcome to contact me and other colleagues so that we can have you as one of the speakers. We know that we cannot replace experience, but also it's good to listen to up and coming specialists and clinicians, so whether medical or also from the nursing fraternity. I would love to hear from you and share your knowledge and your future trends, because we've got even young doctors who are more inclined to using artificial intelligence and quite innovative with technology. So we also want to hear from you. Please do contact us if you want to share your knowledge and expertise on this platform. Okay, Kama, I don't know if Dr. Kgole is able to connect. Doc, if you're ready,
she's back online. We're just waiting for her to share her screen and start the presentation.
Sure. But at least it's given more time to get more people who joined us late to catch the presentation from the beginning. We know that some colleagues are finishing quite late in their practices, so they're joining us in the middle of the presentation. So those who have joined us late, you're fortunate tonight that you are able to catch the presentation at the beginning. But you also apologize for those who joined us much earlier, that you would have loved to have been in the middle of the presentation. But you know that sometimes these things are not within our control, notwithstanding the challenges we have with load shedding and ESCOM challenges. See, Doctor. Are we winning, Dr. Kgole? Dr. Kgole, we can see you're connected. I'm not sure if you're connected with audio. I can see that your videos, you're okay. If you can switch on your video, are you winning with your presentation?
Connected audio. I'm just having a bit of loading. Yeah.
My apologies, I also got bombed out. I've been in and out. Kamuso, I'm sure you saw that you couldn't see me. I also lost, got out. I've got a poor reception tonight. I don't know what's going on. Dr. Kgole, can are you connected? We can see the screen. Can you hear us, Dr. Kgole?
Right.
Yeah, so we could hear you.
Thank you so much. All right. Am I audible now?
Yeah, you're audible now. You just need to share your screen now.
Now audible.
Excuse me?
Am I audible?
Yes, you're audible, but you're breaking up. But if you could share your screen. Yes, the screen is coming up. Yeah, just go to slideshow now.
Yes, I can hear you, but you guys.
Yes, your audio is not one of the best, but
Can you hear me?
May I please ask you to shift around, just trying to get network, please?
or maybe use your cell phone if it's possible. But no, you can't. Are you able to log in with your cell phone?
I've got your slides, Dr. Kgole, as well, so I can share on my end if that would be better.
You've got the slides on Dr. Kgole's side. Yes.
I've got her slides, so I can also share if that will help with the bandwidth on your side.
Yeah, but then she will have to reconnect using a cell phone. And let's see how it is. She speaks from the cell phone. Dr. Kgole?
Can you hear me now?
Yes, we can hear you, Doc.
All right.
Hi, Doc, we can hear you now. Can you just try again? You've got two connections, eh?
Yes.
If you can switch off the other connection and then and speak on one.
Vuyo will have to move my slides.
No. You're connected on two devices. I can see that. You're on two devices. So if you can switch off, can you just speak now? Let me hear. Can you just speak?
Yes.
Okay, the other device is switched off. Yeah, the other device is switched off.
I've switched off the one where I can control the slides.
That's fine. So Vuyo,
Dr.
can you
Bila.
control the slides?
Dr. Bila.
Vuyo? Yes.
May I suggest that Dr. Vuyo controls the slides? and then Dr. Becky presents with the audio.
Okay, I've shared.
That's what I'm saying. That's what I'm saying.
I've shared your slides, Kgole. Can you see them clearly?
Yes.
Right?
Yes.
Okay.
Okay,
All right.
now we can start. Thank you. Thank you.
Yeah, we can see
All
the
right,
slides.
thank you so
Then
much.
then Dr. Kgole, then you can do the you can just do the presentation where you will Dr. Fadana will control the screen.
Thank you. I think this might work better. All right. Sorry about that. This is my disclaimer slide. I'm going to present to you an update on management of nosocomial pneumonia. Next slide, please.
Okay, no, thank you.
All right, this is my disclaimer. This is meant as an educational talk, and the statements and opinions that are voiced out here were formulated through extensive literature review by myself. I've done previous talks for the companies mentioned, and I do not sit on any advisory bodies for any pharmaceutical companies. Next slide, please. So I'm going to start with a background just to give you an impact of the disease that we're talking about today, which is nosocomial pneumonia, which is also known as hospital-acquired pneumonia. So the two terms can be used interchangeably. It occurs within 48 hours or more after hospitalization, and it should not be incubating at the time of admission. It is the second most common cause of nosocomial infection, and it's the leading cause of mortality in most hospitals, leading to both increased length of stay and death from nosocomial infections in critically ill patients. The mortality from hospital-acquired pneumonia and ventilator-associated pneumonia ranges between 20 and 50%, and it can reach up to 75% in some settings. And when the lung infection is called, particularly when the lung infection is caused by a multi-resistant pathogen. Multi-resistant pathogens, just to give you a bit of a definition, are pathogens that are not susceptible to at least one agent from 3 or more classes. Extensively drug-resistant pathogens are susceptible to only 1 or 2 classes of antibiotics, and pen-resistant pathogens are not susceptible to any antibiotics. Ventilator-associated pneumonia represents a significant subset of hospital-acquired pneumonias in critical care units, which is about 5 to 15%. Next slide, please. So HAP results, hospital-acquired pneumonia results from aspiration in patients who are poorly positioned in the hospitals, patients who are constantly sedated in the hospitals, and patients who have a low level of consciousness from various causes. So either head injury patients, patients who are sedated, or patients who came into the hospital with delirium and have a waxing and waning level of consciousness. Inhalation of contaminated aerosols that you can find in the ICUs, and bacterial translocation, most likely due to poor hand hygiene between healthcare workers and not cleaning rooms as patients move and change, get admitted in and out of the hospital. Hematological spread from other sites, so patients can get hospital-acquired pneumonia from another site that's outside the lung through hematogenous spread. Complications of hospital-acquired pneumonia include empyema, parapneumonic effusions, and overwhelming sepsis. Next slide. Pathogens that are commonly associated with hospital-acquired pneumonia, nosocomial pneumonia, include gram-positive cocci such as methicillin-resistant Staph aureus, gram-negative bacilli such as Pseudomonas, Klebsiella pneumonia, Serratia macescens, and Acinetobacter species, and Candida species. In general, methicillin-sensitive Staph aureus, strep pneumo, and Haemophilus should be suspected if a patient has been in the hospital for about 4 to 7 days. And in patients who stay longer than that, you start suspecting organisms like Pseudomonas aeruginosa and methicillin-resistant Staph aureus, in addition to enteric gram-negative organisms. And patients who are on high-dose steroids, you should be on the lookout for Legionella and Pseudomonas infections. In chronic suppurative lung disease patients, such as patients with post-TB bronchiectasis or cystic fibrosis, you should be on the lookout for gram-negative pathogens being colonizers, including antibiotic-resistant strains. There's also an increasing recognition of viruses as a cause for nosocomial pneumonia, particularly in immunocompetent patients. And viruses and fungi are also found in immunosuppressed patients. Next slide, please. The risk factors for developing hospital-acquired pneumonia include host susceptibility, which is underlying structural lung disease, patient being on mechanical ventilation, patient being in a supine position in the hospital for a long time, poor oral care, and physical deconditioning. The risk factors for ventilator-associated pneumonia with multi-drug resistant organisms include non-hospital patients with multiple risks of being colonized. This includes patients who are going in and out of dialysis centers, patients who are going in and out of the hospital for IV infusions, such as patients with cystic fibrosis, patients who live in care centers, frail care centers, also are included in this non-hospital patients who can develop multi-drug resistant organisms. Other patients include patients who've had antibiotics in the past 90 days, who have a need for ventilator support, who have septic shock at the time of diagnosis, and patients in acute respiratory distress syndrome in the preceding 5 days prior to hospitalization. Next slide. As healthcare workers, we should be suspecting hospital-acquired pneumonia in patients who, after 48 hours of hospitalization, start developing new onset fever, cough, purulent sputum production, and they've got declining oxygenation or increase in oxygen requirements. So if your patient is sitting on a ventilator and they've been sitting on an FiO2 of 0.5, and when you come back the next day, your FiO2s are sitting at 0.7, you should be suspecting nosocomial pneumonia at this point. To meet the criteria for HAP and VAP, symptoms should have onset after 48 hours of admission. Signs like fever, increasing oxygen requirement that I've mentioned, purulent material from endotracheal suctioning, cause crackles and rails and consolidation, and signs such as pneumonic effusions should always make you be on the lookout for hospital-acquired pneumonia. So in our therapeutic strategies, next slide, please. In our therapeutic strategies, prevention is the number one key to preventing hospital-acquired pneumonia. So your patients should be sitting in an upright position where they can. They shouldn't be lying flat. You should avoid sedation. They should have good oral care and measures, non-pharmacological measures to prevent hospital-acquired pneumonia should be instituted. Focus on therapy for nosocomial pneumonia should be targeted to specific microbes with information that's guided by initial cultures and sensitivities. So patients who develop signs and symptoms to suggest nosocomial pneumonia should be cultured. You should get respiratory samples, you should get bloods, you should get culture all sites that could potentially be the source of the sepsis. Regular liaison with your local microbiologist is very helpful. I know in both private and public sectors, we've got microbiologists that are always willing to assist you with the choice of antibiotics every time you treat a patient with sepsis. However, the guidelines suggest that the decision to initiate antimicrobials should include assessment for risk of resistance, and it should not only be based on the result of your cultures and sensitivities. So you should have a risk for resistance, and you should be communicating with your microbiologist to see what your antibiogram is in your units looks like, so that you have an idea of what to start whenever a patient develops nosocomial sepsis, depending on their location as well. Next slide, please. So the burden of antimicrobial resistance in ICU and high care is increasing. This is likely due to the severity of each patient's illnesses, their comorbidities and clinical conditions, and frequent antibiotic use that is seen amongst patients who are in the hospital. It is also important just to mention that your infection control measures should always be on point, just so that your patients are at a lesser risk of developing nosocomial pneumonia. Empiric antibiotic treatment must be appropriately administered, and it should be administered as early as possible. Several guidelines have been put together just to assist with care bundles in patients who are hospitalized. So one such guidelines is surviving sepsis guidelines, the European treatment guidelines for hospital-acquired pneumonia and ventilator-associated pneumonia. And there's national surveillance program in intensive care unit for acquired infections in Europe that show that the likelihood of receiving an inadequate empiric treatment, particularly for Pseudomonas aeruginosa infection, even with combination therapy, is approximately 30%. Several studies have shown that appropriate initial antibiotic therapy for patients with HAP and VAP significantly improves outcome, and adequate selection of initial treatment represents a crucial clinical goal. However, the rates of resistance to old antibiotics frequently used to treat HAP and VAP are on the rise, and a growing proportion of pathogens isolated from patients with nosocomial pneumonia now displays multi-drug resistance. Evidence suggests that infections caused by MDR pathogens have worse clinical outcomes, and this is usually because of delay in initiating adequate antibiotic therapy. Next slide. Increasing resistance amongst bacterial pathogens such in HAP and VAP, especially the Enterobacterales and non-fermenting gram-negative bacteria, has made a choice of empiric treatment in these infections increasingly challenging. Failure of initial therapy to cover causative agents associated with HAP and VAP has been associated, obviously, with worse clinical outcomes. There's new drugs that have been approved by the FDA, and some of them we have in the country. These include ceftolozane tazobactam, ceftazidime avibactam, meropenem and vaibobactam, and imipenem and relebactam, and cefiderol and ceftobiprole. They've sort of put a major advantage in the fact that they are highly active against multi-drug resistant gram-negative pathogens. This is a diagram that I lifted from an update of the treatment of nosocomial pneumonia in ICU. It sort of looks at the risk factors for nosocomial pneumonia. So poor chest physiotherapy. So when patients have accumulated secretions that are not cleared, the physiotherapy is not doing adequate chest physio on patients who are ventilated, particularly because they cannot cough. Half of them are paralyzed, and some of them are on sedation. Whether they require it or not is a topic for another day. Poor oral care, oropharyngeal colonization that we have in most patients that are walking around. Sedation and delirium are the risk factors that are put across for accumulation of purulent mucus. So depending on whether your patient is in ward or in ICU, you have a patient who has hospital-acquired pneumonia, and the patients who have hospital-acquired pneumonia that they develop in the ward and end up requiring ventilation have been shown to have a worse outcome than patients who are in ICU and actually develop a ventilator-associated pneumonia. On this slide, I've just tried to put together the indications of the antimicrobials that we have. This I got from a study that was done by the South African group of pulmonologists and critical care specialists of Guy Richards, I think is on those guidelines for what to do with difficult to treat antimicrobials. Of the drugs that we see here, we only have ceftazidime avibactam and ceftolozane tazobactam. It is a few drugs, but they still help us in the fact that they assist us in treating the multi-drug resistant Pseudomonas aeruginosa. They have some cover for some other Enterobacterales, and they've been shown, if given in the doses that are put on the package insert, to have to improve outcomes in patients with multi-drug resistant pneumonia. So various guidelines suggest that the shortest, most effective antibiotic exposure is best for patients until improved stratification scores and clinically meaningful cutoff values to identify MDR are available and externally validated. Decision to start antibiotic for hospital-acquired pneumonia should be based on syndromic antibiograms and institutional guidance. There is a difference in antibiograms in the same hospital within wards. There is a difference in antibiograms between medical wards and your critical care units. And over time, these antibiograms also differ. So the fact that you have an antibiogram from January, you still need an antibiogram in April to treat a hospital-acquired pneumonia in April in your hospital. So optimization of initial treatment, optimization and maintenance doses is another enabler to enhance outcome. So stewardship practices must be streamlined by reassessment to minimize negative effects such as potential increase of duration of therapy and increased risk of collateral damage from exposure of multiple sequential antibiotics that may ensue from de-escalation. So patients with early onset infection and none of the classic risk factors for MDR pathogens should ideally be started on a narrower spectrum antibiotic, such as ertapenem, ceftriaxone, cefotaxime, cefotaxime, moxiflox, and levoflox. This is in patients who are suspected to be low risk. It should be noted that patients of third generation cephalosporins are at a higher risk of getting Clostridium difficile compared to patients who are on penicillins or quinolones. Broad spectrum antibiotic therapy targeting Pseudomonas aeruginosa and extended spectrum beta-lactamase producing organisms should be considered in the following settings. So if the unit has a high prevalence of Acinetobacter species, if a patient is suspected to have early onset HAP or VEP who are in septic shock, patients in a hospital with a high background rate of resistant pathogens, according to local antimicrobial data that you get. Patients with other non-classical risk factors for MDR should also be considered for anti-pseudomonal cover, as well as extended beta-lactamase cover for extended beta-lactamase producing organisms. Antibiotic therapy should be tailored to susceptibility data of the etiological pathogens once the microbial and clinical response data becomes available. So while you do your cultures, you should be starting on empiric therapy, and once this data becomes available, you should be de-escalating or directing your therapy appropriately. Next slide. Select patients with low-risk MDR pathogens. In some patients, high risk for MDR pathogens can be started on initial monotherapy if there's a single antibiotic therapy that is effective against 90% of gram-negative data. Again, this you're going to find on your local antibiograms. But care should be taken with patients who are severely ill with septic shock, because these individuals are at high risk of all-cause mortality, and you don't have time to be wrong with your antimicrobials in the early stages. So combination therapy for high-risk HAP and VAP patients should cover gram-negative bacteria and should include antibiotics that cover for MRSA in patients who are at risk. So patients who should be considered at risk are patients who present with HAP and are in septic shock, or the patients who have the following risk factors that I think I've mentioned before. So patients with I think this slide repeats itself. Patients who have had prolonged hospital stay with previous colonization of MDR, XDR, or PDR pathogens, and patients who have previous antimicrobial use. Zen et al., next slide please, published a retrospective cohort study of 592 patients. This slide I put in just to give you an idea of what you should do with your PCTs when you're monitoring your patients with hospital-acquired pneumonia. So procalcitonin, as useful a biomarker as it is used to predict and diagnose the severity and evaluation of bacterial infections in critically ill patients. It has been shown to be associated with severe inflammation and worse prognosis. So the higher it is, the worse prognosis the patient has. In this study, they included patients with chemotherapy, patients who were receiving glucocorticoids, and patients with bone marrow stimulators, as well as patients with hematological malignancies. The study looked at PCT and other CRPs and other composite markers, and it was shown that even with the application of composite biomarkers, very few studies can give you a suggestion of when to start antimicrobials accurately. So it's always good to rely on your clinical acumen and what you find clinically in your patients. Many studies focused on the significance of a single biomarker, but interest in multiple biomarkers has increased, especially with severity of evaluation of infections such as sepsis, septic shock, and community-acquired pneumonia. Contradictory conclusions have been presented due to the inconsistent results drawn from small samples. Patients with HAP have high levels of PCT and CRP than patients without HAP, obviously, and these patients showed greater severity as shown by the higher Apache scores. Next slide, please. So here I've tried to look at, I've put in a slide just to show you what organisms have been cultured in patients with nosocomial pneumonia. So you can see that your Staph aureus is sitting there, methicillin resistant, some Streptococcus, Enterococcus. Gram-negative isolates included Klebsiella species, Pseudomonas, and Acinetobacter baumannii. Fungal isolates, Candida albicans still makes the list, but there's an increasing prevalence of non-albicans candidiasis. Some viruses and TB was isolated in some patients. Next slide. So prevalence of infections that caused by difficult to treat resistant gram-negative bacteria, which are termed DTR-GNB, is rapidly increasing, along with constantly evolving epidemiology. DTR describes treatment-limiting resistance to all first-line agents, that is beta-lactams, including carbapenems, and previous generation beta-lactam inhibitor combinations, and fluoroquinolones. Worst, difficult to treat infections is by far carbapenem-resistant Enterobacterales, such as Klebsiella pneumonia. Options for the treatment of hospital-acquired infections, including HAP, caused by carbapenem-resistant Pseudomonas, are also scarce, and recent reports emphasize the spread of colistin non-susceptible environments with high volumes of colistin and polymyxin usage, which is a major concern. Here I tried to look at stratified beta-lactamase inhibition. So in clinical practice, when you're looking at your patients and you're looking at beta-lactamase inhibition mechanisms, you're looking at your extended beta-lactamase producing organisms and carbapenemases, and you're looking at your MC producers and other carbapenemases, such as your OXA48. Pseudomonas and Enterobacterales are usually OXA48 producing. Pseudomonas actually can use any of these mechanisms. So it can use a carbapenemase and OXA48 producing NDM, VIM, and IMB, and they can also IMP, and it can also be an MC producer. Other organisms will sort of fall into either an ESBL or a carbapenemase, and these are the therapeutic options that you've got. So for your Pseudomonas and Klebsiella, you can still use piperacillin tazobactam if the organism is sensitive, and then ceftazidime AV, which is available. Estronam ivibactam can be used. Ceftolozane tazobactam and piptaz can be used in sensitive organisms, and ceftazidime avibactam. The problem with some of these drugs is cost, and some of them are Section 21 drugs. So you should familiarize yourself together with your clinical pharmacologist which drugs are accessible in your unit and how to get them. So this slide talks about recommendations for intravenous IV treatment options for extended beta-lactamase producing Enterobacterales. So depending on your site of infection, today we're talking about pneumonia. So when your patients have ESBL pneumonia, your initial treatment is going to be your piptaz or ertapenem initially, and then when this is not sensitive, your alternatives are meronem or imipenem cilastatin. Bloodstream infections, they still use aminoglycosides, but as you can see in the alternative treatment, there's a lot of use of carbapenem drugs, which we are trying to save in our best drugs against most organisms. So this is a recommended IV treatment for patients with MC. So organisms such as Pseudomonas. In your lung infections, you can still use piptaz and cefepime, and the alternative there is still meronem, imi, and ceftolozane tazobactam. Primary bacteremia, meronem, imipenem, ceftolozane tazobactam. And if a patient is sensitive to ertapenem, patients can still be started on ertapenem initially. So when you're looking at your CREs, you can still, for your pneumonia, use ceftazidime avibactam. For your patients that you suspect a GES or KPC or an XR48, Astronam when it's available, and ceftazidime avibactam. I know in the package insert for ceftolozane tazobactam as well, it can be used for hospital-acquired pneumonia. In In the absence of these drugs, your options are still your Meronem plus colistin or any other second active drug. Recommendations for IV treatment for patients who are critically ill. It depends on really your local antibiograms, but you have a choice between all those drugs. And you should always remember that the dosaging in critically ill patients might differ from what you would give a patient who's not critically ill. And that is the end of my talk.
Thank you very much, Dr. Kgole.
Thank you.
Sure, we survived the scare there, and when we
we started,
it was a rough ride.
I hope I didn't rush through the presentation trying to catch up for time.
Well, we made time. We'll be able to, if we missed anything, we can always go back to the YouTube presentation, the recording. But we still have time to go through the Q&A. So colleagues are quite welcome to make comments and ask questions about the presentation. As we're discussing earlier on, Dr. Vuyafadana is also in the field, and so if he's got one or two words to say, he's free to do so. And I've seen quite a number of other colleagues and senior pulmonologists, one or two at least one that I've recognized that I saw who's on the line. So they're quite free to make a few comments or ask questions. But last week we were discussing pediatrics with the nosocomial infections, hospital-acquired infections within the, oh sorry, I must just get out of here. Within the neonatal units. And what I noticed that the microorganisms that are cultured amongst the children in pediatric settings, it's the same as what you culture also in adult settings. Is that a fair comment? My observation is correct.
This is a fair comment. Usually, the organisms that you culture in adults and children will be the same. The differences will just be your drug dosing and the environment which these organisms were acquired.
Okay, so thanks. Yeah, colleagues, you're free to make comments. Those who've got questions or comments to make, please feel free to do so on the chat line, the chat box, and also if you do want to talk, you may raise your hand and make a comment. And it was a bit difficult for me because I also got bumped off from time to time. I lost connectivity, and I might have missed a few other slide presentations. But it was quite a good presentation. And what's your comment about the? Now we'll be seeing any difference in terms of the presentations of cases that we see in pneumonias now as we get into the winter season? And what advice would you give? Sometimes people go see primary health care visits and GP practices, and almost every patient who might be coming with a cough and a sneeze and a light indication of getting a pneumonia, they'll be put on antibiotics. What would you advise for somebody like in a primary care setting or GP practice?
So one of the drivers for antimicrobial resistance is really overuse of antibiotics, particularly when they are not indicated. We should remember that we're going into a flu season, and the bulk of upper respiratory tract infections are viral. So we should avoid trying to put them on antibiotics just because you're worried that they won't come back. Obviously, if a patient presents with fever and you do you examine them and they sound like they've got a consolidation, and you send them for an X-ray, which has a quicker turnaround time, they should be started on antimicrobials appropriate to your local antibiogram, as I always say. Usually your initial beta-lactamases are the first option to go to when you have an indication to start antibiotics. But specifically when you're examining a patient or you're taking a history from your patient and they're talking about a blocked nose and sneezing and things like that, those are symptoms that are more associated with a viral infection. And the presence of a productive cough at that time does not necessarily mean that the patient has developed a pneumonia. So we should be avoiding overuse of antibiotics. As we get into the flu season, the other important thing is to encourage your patients to vaccinate for the local strain of flu every flu season. And it's also quite important that your patients who are vulnerable, so patients with chronic lung diseases and patients who are over the age of 65 should be getting their pneumococcal vaccines, which doesn't prevent them from getting pneumococcal diseases, but reduces the severity of pneumococcal infections once they get them. So that should be helpful in improving mortality and morbidity from pneumonia in patients who are vulnerable.
Okay. No, thanks for that. I think it's some good advice as we enter the flu season, because I thought, this is one of the also bigger problems that we will be facing. And overuse of antibiotics, in a clinical setting in patients. I know that we sometimes you look at children, sometimes you give empiric management, and so you might have covered it in a presentation. So patients who are coming in quite severely ill, high temperatures, and before you culture any organism and you want to cover them, what's your approach then in terms of giving coverage before you get your culture back in the ICU setting that you normally see, or I know that you've given us a spectrum of the prevalent organisms that you culture.
So the European guidelines, and I think the South African guidelines also echo the same sentiment, that empiric antibiotics should be started in patients where you clinically suspect a pneumonia. So you should get your X-rays, you should clinically examine, find a consolidation, hear rails, and all the features that suggest that this patient has a consolidation. These patients, particularly if they are not ill enough. So say this patient comes in and they're in the ward and you've got time to wait for cultures, and you've got time to wait for your CRPs and your PCTs. These patients can wait before you start empiric therapy. However, if a patient presents with a pneumonia and they're in septic shock, you don't have the luxury of time to wait for antimicrobial. So you should go on your clinical assessment and start them on empiric therapy. Depending on where the patient comes from and their risk, you should be able to choose the ideal antimicrobial to start as empiric therapy. So patients who are going to be from the hospital should, as I've mentioned in my talk, receive a anti-pseudomonal cover, and they should have a cover for MRSA, as these are the common pathogens that cause hospital-acquired pneumonia.
Okay. No, thanks, colleagues. You're free to, if you've got a question, you may just put your question in the chat box, or just raise your hand and unmute yourself, and we can talk. Where from your side, seeing that you're in the pharmaceutical industry, what's been in terms of moving towards the flu season, drugs that you see being purchased by practitioners, whether they in the primary healthcare setting, the clinical hospitals, and what's your anticipation, and what has been experienced so far?
Thanks, Ray, for that question. So unfortunately, I don't have a view of sales from a medical perspective, right? So, but one of my colleagues is on the call and hopefully can assist with that question. But I share the same sentiments that Dr. Kgole mentioned, that vaccination is still quite important. So prevention is better than cure. So patients that are at risk should be vaccinated. There's a pneumococcal vaccine that's available for elderly and for kids. The flu vaccine is always a must, especially for us as healthcare workers that work with patients. We need to be vaccinated. People that are at risk need to be vaccinated as well. So vaccination is quite important for prevention.
And it's not only for people who are quite advanced in age that but it's people who've got also COVID diseases should also be vaccinated.
Should also be vaccinated, yeah.
Okay.
So maybe just a comment from my side. Thanks, Dr. Kgole, for the talk. So I know some of us on the chat might not be familiar with the new antibiotics that have been recently registered. So MSD, we've registered ceftolozane and tazobactam. We launched it last year in September. It's currently registered for the 3 indications in South Africa: complicated urinary tract infections, complicated intra-abdominal infections, at a dose of 1.5 gram IVI 8 hourly. And it's also registered for the treatment of nosocomial pneumonia, both HEP and VEP, at a dose of 3 grams IVI 8 hourly. So I'm more than happy to share the clinical trials around those registrations with anyone that's interested. Also, I'll also be happy to come and maybe present on this topic at a later stage, Dr. Bila.
Okay. No, thanks. It's an open platform. We encourage you not particularly solar to any idea, but just to share much information as broad as possible. Maybe back to you, Dr. Kgole. As a pulmonologist, I know that people have got COVID fatigue, but maybe just your experience, because it's not often that we get a pulmonologist being part of this. And lo and behold, maybe we should not get COVID again, but the approach that was being promoted by 1 or 2 pulmonologists in the past about not just only giving medication, but also surgical management of patients with COVID as pulmonologists. Now that the dust has settled, what is the verdict now, looking back as to what was happening? And one of the colleagues in Pretoria was much covered in the media about the approach and the intervention that he was doing at the time.
So, Dr. Bila, now that the dust has settled, and unfortunately COVID numbers are trickling in. I don't think they're going up, but there's still a couple of patients who are admitted with COVID positive with quite severe disease. But particularly the elderly are still being admitted with COVID. Mm-hmm. The interventions that we have for COVID, there isn't much. No study has been, no randomized control trial has been done to prove that one intervention is superior to another, except with regards to steroids, particularly in this case, dexamethasone was the one being used. Over time, over the waves, the vitamins fell off favor. There was no mortality benefit from using the vitamins that we threw at patients during COVID. Because of the possibility of thromboembolism in COVID, anticoagulation was important. So we still have to put the patients on anticoagulation. And because it's a viral infection that depresses your immune system, it is still important to look out for superimposed infections and treat them accordingly. Unfortunately, because of the severity of ARDS that can be caused by COVID, we find ourselves with prolonged ICU stay that puts us more at risk for having hospital-acquired infections, hospital-acquired pneumonia, ventilator-associated bacterial pneumonia, as well as ventilated hospital-acquired pneumonia from these patients because they stay in the hospital for too long. As for other interventions that we have been seeing, there hasn't been a randomized controlled trial to prove that it is superior to any other treatment. It is, bronchoscopies are indicated in patients who have copious airway secretions that are causing their airway resistance to go up, and they are messing with your gaseous exchange. But besides, outside that indication, I don't think it's a routine test that you should be doing just because a patient is COVID positive.
Okay. Thanks. Yeah. There was one of the professors, I'm not sure if she will be okay with me maybe just asking it to Professor Michelle Wong. I know that she's on the line. You may know her, I don't know. One of the experienced, pulmonologists was a long stint at Chris Anibara. I don't know if you've got any comments to make, Professor Wong.
Thank you, Ray, and thank you, Becky. I'm always very proud to see one of our trainees progress in her career, and it's really nice to see Becky giving talks now and teaching all of us. I don't really have any specific comments except to say, as has already been mentioned, that we should remember that nosocomial infections are potentially preventable. And as Becky did point out, we should be perhaps putting more effort into preventing them because treatment is very expensive. It carries high morbidity and mortality. And it's really the simple things. Becky has mentioned these, but, doctors and nurses are very bad at doing things like simple hand washing, looking after IV lines carefully, central lines in particular. So I don't really have much else to add to that. These new antibiotics, as Becky mentioned, are extremely expensive. All new drugs have potential side effects that haven't really been well established. And we have seen that happen with antibiotics that we now use commonly, that, the side effects when they were originally launched were not so well known. But as we use them more and more, we find out that there are detrimental effects to any drug. Becky, I may have missed it, but do you want to comment on the duration of antibiotic prescription in these patients?
Yes, thanks, Prof. So in patients with nosocomial pneumonia, the current practice is that you follow their CRPs and PCTs as they decline, and you don't necessarily have a set number of days that these patients are going to be treated for. However, for infections like Pseudomonas and methicillin-resistant, Staph aureus, they always have a longer duration to respond. So we should be following our biomarkers to see when to stop antimicrobials in patients with infections.
Okay, thank you very much. And thanks, Michelle, for allowing me to abuse you by asking you to make a comment. But it's great to hear you and to know that you're part of the chat this evening. There's a question from Dr. Baruch Setiran. Can you please comment on community-acquired pneumonias, though the talk is on hospital-acquired pneumonias? With the current flu epidemic, I think we mentioned that just coming up now, we are seeing many patients with atypical pneumonia. So can you comment on that, Dr. Kgole?
So we should always remember that pneumonia is an inflammation of the lung that can be caused by both viruses and fungi and bacteria. So it's important to always try to, particularly in the community, delineate whether you are dealing with a viral pneumonia, a bacterial pneumonia, or a fungal pneumonia, so that you don't have overuse of antimicrobials in a setting way they are unnecessary. Particularly with the flu season, as I've mentioned, a lot of patients are going to come in with pneumonia-like symptoms, but you can actually, from taking your history, figure out whether a patient is presenting more with a viral infection or a bacterial infection, particularly if you auscultate the patient and they don't have areas of consolidation, they're not necessarily presenting with a fever, and they're coming in with more upper airway symptoms. Then you're most likely dealing with a viral pneumonia instead of a bacterial pneumonia, and you should not be starting patients on antimicrobials.
Okay. A similar question, but it's about prevention. During COVID, we did see many patients presenting with respiratory tract infections, mainly by people not exposed to much droplets extensively because of the mask usage. The question is, will you advise wearing face mask in hospital as a prevention beside vaccination?
As we've seen during the COVID pandemic, wearing face masks prevented spread of the disease. So in my view, if you're working with respiratory patients, just like the dentists are doing, they're always in the patient's mouth, so they're always wearing masks. We should be wearing masks if we're dealing with respiratory patients. The practicality of it, it's very difficult to walk around with a mask all the time. So it ideally should be done, but I don't think it's practical. For patients for doctors who are working, for instance, in the TB ward, they should be wearing N95 masks because the normal cloth mask, the normal surgical masks are not adequate. But outside that, I think it's a practice that's going to take a long time to get the hang of the fact that when you're working in a respiratory unit, you should be wearing masks.
But you reckon it should be a practice, it should be normalized?
It should be normalized. I think it should be normalized because some of the viruses, I mean, we've had an RSV, a spike in RSV infections recently, and the patients were actually coming into hospital because they thought it was COVID, and the cough from the RSV was actually quite debilitating for patients. So you can imagine if you come into a hospital and I'm treating a patient's RSV and I'm spreading it around to all my patients because I'm the one seeing each and every one of them without a mask. So it should be normalized, I think.
Sure. Yeah, this Dr. Raul Bagondas wants to know, Dr. Kgole, at what point should steroids be given in severe pneumonia? Because they indicate that new studies seem to be showing that there is a lot of benefit from starting patients on steroids in severe pneumonia.
So, if Dr. Bagondas is talking about severe pneumonia, corticosteroids have been associated with a lower incidence of progression and of requiring mechanical ventilation in patients with hospitalized with severe pneumonia. However, there's been no real association with mortality or a mortality benefit or adverse events with corticosteroids, particularly in the face of overwhelming sepsis causing an Addison's crisis. Steroids are definitely beneficial, but I think it's not standard of care to just use it in everybody. The choice to use steroids should be individualized to patients. We must also remember that steroids have a potential to worsen viral pneumonias if they are started too early, as we might have seen before the COVID wave, when patients with viral pneumonias were started with corticosteroids. They also predispose you to superimposed bacterial infection. So in severe pneumonia, I would use steroids, but I think it should still be individualized.
Okay. So as you are saying that, your clinical acumen should be telling you what to do more than anything else. Thank you very much. I think we don't have any further questions. We managed to cover a lot, despite the that bubble that we had at the beginning, but we've covered quite a lot. And I'm going to ask Dr. Fadana Vuyo just to do a closing remarks, and then we'll leave it at that. Vuyo?
Thanks, Dr. Miller. Just want to say thanks to everyone for joining today's call, and thanks to Kgole for taking the time to prepare the presentation. We've actually, I'm sure we've all learned a lot from it. We're looking forward to partnering further with the clinics group in bringing these CMEs to our clinicians.
Thank you very much for the invitation, Dr. Fadana and the clinics group.
It's been a pleasure being with you this evening, Dr. Kgole. And thanks, colleagues, for those who've joined. Dr. Fadana has just sent a vote of thanks, and we just want to thank you for always joining us at these webinars. And also thanks to Gamo. We've got a good partnership, Gamo, from our marketing division within Clinics Health Group, making sure that we have these webinars every week and providing technical support in the background. And so next week, colleagues, it's a public holiday, the 27th, so we do not want to interfere with your time with family or plans that you have in celebrating freedom. But then we will then continue next month, the focus will be purely on ethics in the month of May, if we can help it. But you also know that there's also nurses celebration, so we also want to have a dedicated day to celebrate nurses around International Nurses Day. But I just want to thank you for joining us, and that you've been quite a appeal of strength to us for supporting Clinics Health Group with these presentations, and the various speakers that we have, people of the caliber of Dr. Becky Kgole, who are sharing the expertise and knowledge and experiences with us at this webinars. And so till we meet next time, may you have a good evening.